This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
It's a pleasure to be invited to share my thoughts on how clinician-administrator relationships can be optimized. And it's great to be able to share the panel with two old friends and colleagues, Rob Perkis and Harvey Lander. More than 20 years ago, as a junior registrar at the Royal Prince Alfred ICU, Rob Perkis was my boss. He was one of the consultants there. He wasn't a director, but he was one of 4 consultants. Just a little bit about where I work mostly. This is obviously a photoshopped picture of Concord Hospital. If you saw the news last night, both Channel 9 and Channel 7 had a feature on Concord. The article was mostly negative. It was about the rundown nature of the hospital, asbestos, possums, beehives were all featured. But despite that, we have a very proud heritage. And I believe we have a very strong culture in patient safety and quality. It's a 600-bed hospital, medium-sized, teaching hospital of the University of Sydney, about 13 kilometres from the CBD. It's in a lovely part of Sydney, surrounded by water, but needing some work when it comes to renovation. It was last renovated about 15, 16 years ago, just before the Olympics. And at that stage, even the Olympics chose Concord to be the official hospital because of its newness. But that's now a very, very long time ago. Probably not as busy as some of your hospitals, but we see about 800 ED presentations a week and has a very busy set of outpatient clinics. Has 11 theatres, 1 dedicated burns theatre, and do about 12,300 procedures a year surgically. But let's go back to the rapid response systems and MET. What do you think I want from you? Well, I don't want to be seen as the oracle or the spokesperson of medical administration. If you violently disagree with me, please interject and interrupt. Harvey, you may actually suggest other points as I go along, but it's my view and they are my thoughts, and I would like to mention 5 things that I believe would optimize clinician and administrator relationship. Number 1 is keep doing what you're doing. This is now the 12th year of the international conference, and I know ANZICS has the annual quality and safety conference as well, so you do it regularly. I'm so impressed by the high caliber of scientific research and audits that you guys have all put in regularly. We have come a long way from 20 years ago when the pioneering research from Professor Hillman and others started the whole MET revolution. Now I can see that it's truly a multidisciplinary system. Rob, it's a system. It's no longer just a domain of intensive care clinicians. Now it involves, even in this conference, people from obstetrics, from mental health, from medicine, from pediatrics, etc., even administration. So thank you for inviting me. And I know that there are some consumer representatives during the last 2 days. So well done in doing what you're doing and keeping the community engaged. So keep up the good work. Number 2 is to collaborate with the administration, with the executive, for the sake of our patients. Administration really is not the enemy. In my hospital, the clinical emergency response system is run by an intensive care consultant along with a senior nurse. That's Winston Chung and Vinita Sahai. They're both here in the last 2 days. I have a very, very good working relationship with both of them, and we have a close, transparent, and open communication. And I see that we are cross-accountable to each other. All hospitals need to have a robust reporting structures between the people that run SIRS, or whatever you call it, as well as the executive. And the good work, of course, of evaluation, audit, and feedback need to be continuing and communicated directly to the executive. My ears are always open to new suggestions based on data, and the evaluation and good work that my doctors and nurses have done had helped improvements in the hospital. Number 3, facilitate improvements with the help of the central agencies. What do I mean by central agencies? and these are the federal and state departments of health. They can be the pillar organisations like the one that Robert works in, the Australian Commission of Safety and Quality in Healthcare, or they can be state-based organisations like the one that Harvey works in, the Clinical Excellence Commission of New South Wales. So central agencies are not the enemy either. We have to work with them, and I have to be very careful because my two colleagues are sitting right there in front of me. They're going to throw things at me if I say the wrong thing. And I heard the Commission's presentation this morning, and I thought it's very impressive what they have done. They are listening to clinicians, and what Sue Ellen said this morning showed that you are having an impact on what they're doing in their review of their current version. So my encouragement to all of you as clinical experts is to keep informing and advising these central agencies to help them help you. We don't need more charts. So I thought I'd put that in. It's a bit of a joke, but sometimes we, as people, get bogged down by charts and guidelines and pathways and forget about the culture and the importance of setting the good example. So it really is about facilitating change and doing it with the help of big central agencies. So thank you for being here, Rob and Harvey, because you're hearing what the people out there are saying in the front line, and they're going to tell you what works and what don't work. So keep it up. I'm told there are about 12 committees and 36 working groups that the Commission is looking for membership. So now's the time to enroll, and Rob's here to take any offer of enrollment. Number 4, evaluate what you are doing. I mentioned it briefly. You know that. Evaluation, audit, and feedback, these are the mantra of the Commission, and you do that well already. But I do want to encourage the smaller hospitals who may not be doing it as much to start doing it more. And maybe it's about getting resources to do it. Maybe it's about getting help in getting a business case done to get the executive to support it. And we're here to help you. Shane might shed some light in his next talk about how to get business cases done. Again, at Concord Hospital, I work very closely with Winston and Venita. And in November of 2013, or thereabouts, they started a study that was fully supported by the administration. And the safety and quality manager of Concord even was one of the co-authors eventually. It's a study that was published eventually in the MJA in November of 2014. And it's a study to look at the incidents resulting from staff leaving normal duties to attend medical emergency calls. Now that study was done by the clinicians with the support of the administration, and I offered the quality and safety manager time to help do it. And the results have been useful in the hospital understanding process. And one of the recommendations is about changing the tier system from a 2-tiered system to a 3-tiered system. So that kind of work, that kind of research is active and help guide policy change within the hospital. So I encourage more of that to be done within your institution where the clinical side and the administration side can work together hand in hand. And let's go back to the slide I was in. I was on number 4, evaluate what you're doing. Feedback is very important, and ultimately it's about the patients, and it's about workflow for the doctors, workflow for the nurses. In that particular change, we resulted in satisfaction from staff because their workflow has improved as a result of a changing system. We will be evaluating outcomes, but the early indication is that there's no change in, no deterioration in patient outcomes. My final point, the 5th point, is to seek broader clinical perspectives about what you do. That's in particular when it comes to advanced care plans and end-of-life pathway. It's an area that clearly needs more work, and I encourage the college and the society to keep contributing to the development of system and pathways in that area. Tracy Greer is sitting in the audience. She's my district's end-of-life care pathway coordinator, and she'd love to hear from you about ideas and suggestions of how to actually improve it, how to implement it, and how to make it more visible in your workplace. So in summary, there are 5 points. Firstly, keep doing what you're doing. Secondly, collaborate with the executive, collaborate with your medical directors, your general managers for better patient outcomes. Thirdly, change with the central agencies. Fourthly, evaluate what you're doing, see the results, implement change. And finally, keep seeking broader perspectives from other specialties, from the consumers, from the patients, and from across yourselves. So thank you for the opportunity, and I look forward to some questions at the end.